Hi, I'm Laura and I'm here to do a second video for you on the topic of hip dysplasia. Today we are going to be going a little bit more in depth on the diagnostics, on the x-rays, the scans that you'll have to determine whether or not you have a diagnosis of hip dysplasia. If you haven't checked it out yet, the first video in our blog is on hip dysplasia in general, so it's going to cover a little bit of everything, what it is, what symptoms you might have, the risk factors associated. So if you haven't seen that one already, go back and give that one a little look. What we're going to talk about today is the lateral center edge angle, the Tönnis angle, and the anterior center edge angle. So I've got a little bit of a table in here. We'll summarize all of this for you in the show notes to give you a little bit more of a summary, but this is what we're going to be talking about today. And the first one that we're going to start with is the lateral center edge angle. This one is one that's going to be taken from what we call an AP view. Now, the AP view on an X-ray stands for anterior posterior. So you'll be standing square on, like I am here, taking a picture from front to back. So with that angle, what that's going to do is to help us to determine, we'll get a little bit closer here. This circle here is determining the head, and this blue line here is depicting the socket in terms of the coverage. So what they'll do on an X-ray is they'll take a picture, they'll find the middle of your head of your femur, the ball, and they'll draw a line directly upwards. And then what they'll do is they'll find the edge of the acetabulum, so your socket that's going to come over and show how much coverage you have over the ball. They'll draw another line from that center dot to that angle there, to that edge there. And then we'll decide the angle between the two. So that is your lateral center edge angle. That is going to determine how much coverage you have. So with dysplasia, if you don't have very much coverage, it's going to give a lot more instability in the joint. The more coverage you have, the more stability you have in the joint. And there's a level of that coverage that is an optimal level. So with the dysplasia diagnostics, we have in our table here the lateral center edge angle. If it's over 25 degrees, that's pretty good coverage and you're going to have a nice stable joint. Between 18 to 25 is your borderline. Okay, so this is where we're saying there's some instability. We don't know if it's going to give you troubles yet or not, but we're going to monitor it and see what happens and see what your symptoms are telling us. And then if we've got less than 18 degrees, that's known as pretty severe. And that's where we might be sort of having conversations a bit sooner about what other sort of types of management and help that we can give and support you. So that's the lateral center edge angle. So the next angle that we're going to talk about is our Tönnis angle. So this is another one that's taken front to back in our AP X-ray, and this one is determining something different. So instead of this being the amount of coverage that we have, this is determining the angle of the acetabulum, the socket. So in this diagram here, we've got the ball, which is again representing the head of the femur, and then this red line here is representing the angle of the socket. Okay, so with this ball socket joint, we are trying to determine whether the angle of support is like this, whether it's like this, whether it's like this, and again, how much stability we're getting from it. So this is just another representation. You won't always have this one done. This is one of the other options, but again, really useful to understand what these words are when they're floating around when you're going in for these appointments. So what they will have to do for this one is to take a picture of the whole pelvis and determine a level height. So that's what this line is below here. So it's establishing a baseline for what angle your pelvis is sitting in neutral. Because sometimes when we're standing or we're laying, we might not be sitting completely even. So they have to use some of the bony landmarks in your X-ray to determine what makes the pelvis neutral first. And then from there, they're going to determine this angle of the roof of the acetabulum. So that again is just telling us the level of stability that you've got and how much of a weight-bearing surface you've got. So if you've got a weight-bearing surface that's this angle, it's not going to give you as much stability. If you've got a weight-bearing angle that's a little bit more across like this, it's going to give you much more stability and a little bit more of a load-bearing surface. So in terms of our angles, what we're looking for is that your angle is ideally between 0 and 10 degrees on your X-ray for your Tönnis angle. Anything more than 10 degrees is regarded as something that's going to be need for further investigation to see what's going on, to see again what other treatments, what other help and support that we can offer. Having more than a 10-degree angle is just an indication of slightly less stability within the joint. So the last of the X-rays that we're going to talk about today is the anterior center edge angle. Okay, so this one is taken from a false profile. So where the others have been taken front to back, this one we're going to come from the side angle. Instead of it being a lateral, which is out to the side stability from this way, we're looking at the amount of coverage that you have forwards and backwards now for this one. So in this diagram here, we're imagining that that x-ray has been taken from the side in what we call a false profile view on an x-ray, and it looks like the same diagram. Essentially, it's very, very similar to the lateral center edge angle, but because the x-ray has been taken from a different angle, it's giving us different information. So it's telling us how much coverage we have front to back over the head of the femur. So again, the line is drawn from the center of the head of the femur and drawn straight upwards, and then the line is also taken to the edge of the acetabulum coming forwards, and that line will be drawn to that edge and that angle determined between. So what we're looking for ideally on an anterior center edge angle is that we've got an angle of between 20 and 45 degrees. If we've got that, we've got really good coverage coming forwards. We don't have that anterior instability. If we've got less than 20 degrees, it just makes us question how much stability we have, what extra strength we might need to be able to get, or it might help determine surgeries that we might be having going forward. So all of these are really, really useful information to have when we're thinking about our dysplasia diagnosis, what it is that we need help and support with to help determine whether we can be using conservative management, which is non-surgical, non-invasive intervention, or whether we need to be progressing this up to see a consultant to have a bit more of an in-depth discussion about what non-conservative, so surgical or invasive management might be appropriate for you. So I hope that was useful for you. Let us know if you've got any questions or if you've got any more specific topics you want covered on hip dysplasia. While you're here, we also have some other really amazing blogs on other topics as well. So take a little look while you're here, and we will be back with more videos soon.